Hello and welcome to the Headache Doctor podcast, where on this podcast, it's our mission to educate and empower everyone with headaches and migraines so that you can break free from a life of fear of your next headache or migraine and dependence on medication. If you're listening to this podcast and you have joined in within the last year, you have not heard me talk about vestibular migraine. This is a very common diagnosis out there, and it's a very tricky set of symptoms to treat. I want to talk about it because it's very debilitating and something that usually when you get the diagnosis does not connect to anything objective. And what we want to do on this podcast is find the objective things, find the very practical things that you can do to start changing your situation. I'm Dr. Taves. I'm the founder and one of the headache specialists here at Novera Headache Center. We have locations in Colorado Springs and Parker, and we treat things like vestibular migraine every day. And we provide people with solutions and hope, even when they're in the midst of feeling like there is no hope or you've tried everything. So today, specifically with vestibular migraine, we're going to dive into the diagnosis, how you receive that diagnosis, what does it mean? We're going to include things like understanding the framework behind dizziness and the different systems involved when we get dizzy. And then we're going to end with how to treat it. What are practical ways that you can actually treat this, and what is a framework that should be set up for going through treatment when you're looking to find relief from vestibular migraines. Okay, first off, the diagnosis. The diagnosis, just like the diagnosis of migraine, is really a diagnosis of exclusion. What that means is typically when you have a vestibular migraine, you are dizzy, but it's also accompanied with potentially a history of migraines. Maybe there's headaches, maybe there's a visual disturbance or an aura, maybe there's just a general feeling of being off, or potentially you're just in this state of dizziness. It can either fluctuate and be intense or like a low-grade dizziness that is absent from anything that the ENT has found, or maybe your primary care doc, neurologist, maybe even a vestibular therapist. So you have these different providers you're going to see, and they basically can't figure out why you're dizzy, and then oftentimes you just land with, oh, this is vestibular migraine. I think it odd that our healthcare system provides a diagnosis of vestibular migraine, and it feels like some sense of relief, or like, oh, we understand this, when really that there's no sense of like, okay, now we know what's happening. And there's many diagnoses like that in our healthcare system where they don't actually understand what is happening. They're just saying that you fit into this category of people that have these similar symptoms. Now, one thing that can come about from that sort of strategy or structure to providing a diagnosis is saying that, okay, these people, even though we don't understand what's going on, tend to do well with these treatments, okay? So I'm not saying it's like inherently wrong, but it's not like an exciting thing, like, oh yeah, now we know, because you don't really know. And oftentimes the treatments that are ascribed to these diagnoses are medication-based, right? So because we don't have the objective thing to treat, then it has to be symptom management. And symptom management is largely medication use. There are tips and tricks on how to like mitigate your symptoms when it comes to vestibular migraine or just migraine in general. But that's essentially what's going on here, okay? That's not like, we're not mad at anyone. We're not saying like, oh, we're doing something inherently wrong, but it's just there needs to be more. There needs to be something objective. We need to search for the thing that is actually causing these symptoms. And then once we find it, we need to understand how to break that down and restore the body to its normal function. Okay, so it's a diagnosis of exclusion. So what does it mean to have vestibular migraine? So as I mentioned briefly, there's going to be a component of dizziness, right? So it could be that intense dizziness that's in a shorter window, and it feels like it's just accompanying your migraine. So the migraine hits, maybe you have the visual disturbance, some other sort of aura, and then your primary symptom is dizziness. Like you just feel really dizzy, off, nauseous, that sort of thing. It's not always accompanied by pain, so head pain isn't necessarily needed to get this diagnosis. There's definitely plenty of patients we've seen that don't have head pain associated with their vestibular migraine. But it's more so the fact that you don't necessarily have this inner ear problem. They can't figure out why you're dizzy, but you have these sort of attacks of dizziness every now and then. Okay, nausea is definitely going to be a part of that. You're dizzy, you're nauseous. Maybe there's vomiting associated with it. We've talked a little bit about cyclic vomiting syndrome on this podcast, and that's something like vestibular migraine. If it's repeated in a cyclical fashion, like sometimes it's monthly, and we'll start in little kids, you might get that diagnosis of cyclical vomiting syndrome, which I did talk about probably several months ago on this podcast. So if you're interested in that, go back and search for that in the prior podcast. But when it comes to vestibular migraines, there's the dizziness component, and it's not always associated with head pain. Okay. Now, the other thing that can characterize vestibular migraines is this low-grade dizziness that's just kind of there all the time. Okay. And that low-grade dizziness can be really debilitating. You just feel like you're off, like you're on a ship. You are disoriented. I mean, you're not like stable. And so you might look relatively okay, like once you're moving or walking or that sort of thing, like you can function okay, but it's just this aggravating amount of energy that needs to be put into like compensating, because you're always sort of dealing with that feeling like you're on a ship, or like a slight level of nausea, lightheadedness, like you just feel off. Okay. So these symptoms and how they present, I want to bring you into, as a provider here at Novera Headache Center, how we would look at this set of symptoms and how we would classify it, and then how would we frame out a treatment approach and then go through that treatment approach. Now, one thing before we jump into this that has been coming up in the, it's a regular thing that we have to jump into conversation with our patients. But one of the things we have to do really well here at Novera is position sort of the mental perception of what it takes to get out of these conditions. Okay. Now, we live in a culture that everything is fast, right? Like we value the things that are quick and fast, and then we validate how we feel as like, okay, this is truth. Okay. And so those things aren't necessarily wrong. Like it is helpful that we can, have a computer and a phone, a smartphone that allows us to be way more productive than we were, 50 years ago, right? Like we can consume a lot more and do a lot more than we did back then, right? But there are trade-offs here. And so the trade-off would be that we get in this mindset of everything needs to be quick. And so our healthcare system's quick. The solutions to problems need to be quick. They need to be easy. And so that we can reach a lot of people very quickly and provide them with as much relief as possible. Like that's ultimately the goal. And I would love for that to be the case. And by no means is Novera saying, hey, we want to be as slow as possible. That doesn't make any sense. We would love to be as fast as possible as well. But what we run into is reality. And reality in these situations with the trickier presentations of migraines is that oftentimes it does need to be slow. And so we need to ask the questions of what is the objective thing, right? So oftentimes people come to us and they don't really have anything objective yet. People have been trying, but nothing has really been found. You've been trying treatments, they've failed. And so what we want to do is enter into, okay, let's just ground ourselves in what we know to be true. And there's two questions to ask here. One is, what does the patient have? What do you, the individual, have that presents as like an objective thing that needs to change? And then what do we know of, in the case of vestibular migraine, as systems in the body that will trigger or contribute to dizziness or the vestibular migraine itself, like these sets of symptoms, okay? So whether that's head pain, dizziness, low-grade dizziness, intense dizziness, things like that. Okay, so both things. So if we use like maybe a scientific method or just like understand what is true, what we know to be true, then we need to act on that as opposed to continuing to guess, right? And so we move forward with that. We say, okay, what objectively needs to be fixed? And then what things contribute to dizziness? And those things matching up puts a really good framework in place for knowing, okay, these are the things that we're going to treat. Now, what we need to do, and especially in like vestibular migraine, chronic daily headaches, these trickier situations where the brain is heavily involved, meaning the brain is really sensitive to what's happening. The brain is going to be very in tune, and probably too in tune with anything that happens to these areas, whether it be like upper neck, jaw, tension through the shoulders. And so there's a sense of like especially initially in the process of starting to treat these areas, we need to understand that your symptom reduction isn't necessarily going to indicate or validate you doing the thing, you doing the treatment, right? I've used the example before of like trying to lose weight and you like eat a salad for a week. And I mean, I think if you're trying to lose weight in a week, you'd probably lose a few pounds if you just like went to salad. But ultimately, if you're like, I need to lose 50 pounds in a week by eating salad, otherwise like salad's not the thing. And I'm just going to go back to, drinking pop and going out to eat fast food all the time. That would be unreasonable. And that doesn't make any sense. And so when we look at something like losing weight, all we need to do is say like, okay, if you have more calories coming in as opposed to calories that are expended or that you're utilizing throughout the day, that needs to be different. Like you need to have less calories coming in than your calorie expenditure, and then we'll lose weight. Now, there's scenarios where I'm oversimplifying that, but that's, for the sake of this example, that's what I'm talking about. And so we don't need to like question that strategy when it comes to weight loss. And so what I'm saying here is the same. Like we don't have to question that we're improving a thing that contributes to dizziness. And then over time, we just need to understand how effective it's going to be as far as symptom reduction. So again, same as weight loss. If there are people where they're like resting metabolism or like their inherited genetic, like your metabolism is either ramped up and it's like really good or it's dysfunctional and all over the place. And so if you have a great metabolism and you just can lose weight really fast, like you probably don't need to do much and it'll just like boom. You'll see the improvements really fast. You'll see the weight loss really fast. Now, if you don't, and your body has all this other stuff it's dealing with, like it's like you have stress, you have other conditions, you have chronic illness, you have things that are barriers for you losing weight, you could do the same thing as the person that is in a better environment, but the result is going to look different. Now, does that mean the thing you're doing is wrong? No, absolutely not. And you shouldn't use your relief as validation of like, excuse me, should I do this thing or not? And so when you're evaluating treatment approaches, and I've talked about this before, it needs to be through the lens of like, what is my body intended to do? And am I restoring something in the body, moving towards a direction of what should be, or am I just treating symptoms? Okay. So we always want to be in the category of restoring something, restoring a function in the body that should be there. Okay. So largely medication, I'm sure there is an example out there, but I can't really think of one off the top of my head where a medication is restoring something that is naturally happening in the body and is not like synthetically impacting something. Meaning medication might be putting something into the body that would naturally be there, but is it helping restore the body to naturally do that thing, right? So it's essentially, and the phrase is slapping a Band-Aid on it, right? We don't want to do that. We want to get the body to do the thing itself. Okay, so why am I framing all of that in this conversation? I'm framing all of that because vestibular migraine can be tricky to treat, and we do have to be patient, and oftentimes there's not like this quick turnaround, all right? And so we have to evaluate, am I doing the objective thing that's going to improve something in my body that is connected to dizziness and my symptoms that we know is off? And if we can do that, if we can get in that framework, then we kind of remove ourselves from the symptom reduction, especially in the short term. The reason that that's helpful is because the patients that do well in these trickier situations are the ones that stick with us. I would say if there's going to be people that don't find success, whether it's like chronic daily headache or vestibular migraine, it's because they sort of like, they're constantly evaluating like, all right, if I don't feel better by this date, I'm going to stop. And we will say it till we're blue in the face. Like you might not even feel better. Us working on these areas that are the problem areas, like it might even stir things up. Like it might be a little bit like, this icky feeling. And that's because the body's compensated for so long and you've just been dealing with, whether it's a neck, jaw, shoulders, that they don't know how to function. And so you've been functioning in a way that it thinks is like, quote unquote, okay, but it's just not. And what that's led to is sort of a recalibration of what normal is. And what normal is like your brain getting some mixed signal that puts you in a state of dizziness all the time. Okay. Now, because the treatment takes a while and is hard, like, does that mean that it's not the thing to do? No, absolutely not. Like it's the thing we need to do. And so these are just, they can be tricky situations. Now, occasionally, we will have people with vestibular migraine that find relief pretty quick. So I'm not saying if this is you that, oh man, it's just going to take a long time and you just have to like mentally stick with it, or it's going to get worse before it gets better. That's not, it really is dependent on the patient situation. We typically know how it's going to go relatively soon. But if we overpromise and say, hey, you're going to feel way better like a few visits into this with these specific scenarios, it's really going to be challenging for that person to stick with the process. So framing it is important. Okay. Now, why is this challenging to treat? So dizziness involves three systems. So we have the inner ear. This is the vestibular system. It has these three canals with fluid, and if there's a little crystal called otoconia that finds its way into one of these canals, it'll disrupt that flow of fluid. So the fluid is always, it's like an inner tube with water in it. If you turn your head, look up and down, side to side, that fluid is responding to those movements, and then your brain understands like, okay, I'm not actually spinning, my head's just turning, and then you're able to turn your head quickly and not get dizzy. So the inner ear is going to be a component of dizziness, and it's probably the first line of like what's happening. We will look at the inner ear, like ENTs, vestibular therapists, audiologists will look at the inner ear, the vestibular system, in cases of dizziness, and are usually pretty good at screening it. There are some scenarios where the vestibular system is involved that they may not catch, but overall that's one of the main components when we think of dizziness. Because that organ is basically there to make sure we don't get dizzy when we're not like spinning around, okay? The other system that's involved is the visual system. This system is a little bit trickier. Just going to see an optometrist or ophthalmologist is probably not sufficient. You would need to find an optometrist that is probably trained or well-versed in vision rehab, and there's a specific sort of plan or evaluation treatment process for vision therapy that a good optometrist that specializes in that would understand and know how to take you through. And so the eyes may be a part of it, and that's something that, again, can be overlooked, but our healthcare system does an okay job. I mean, if you go to an optometrist and they're like, well, I don't really do a lot with vision therapy, go see this optometrist. Hopefully that's how that works, because typically in any larger city, they will have a few options as far as vision therapy is concerned. And then if you live in a smaller town, maybe you have access to one in the nearest, bigger town. And when I say small town and big town, what I'm picturing is I went to a small school in Iowa, a town of 6,000 people. And then it's like Sioux City, I guess, would be the spot that you'd probably, anyways, you get what I'm saying. Okay. From there, we, the other system involved is going to be the neck. So the neck is, it's called our proprioceptive system. So basically our brain gets information from our joints, from our muscles, as far as like where our head is, if we're turning our head, if we're looking down, looking up, if there's tension through our neck. And so there's all this feedback from the muscles and joints themselves to the brain. And so we don't have to like look at our body to know where things are. Our muscles just get that information to our brain, and our brain knows. Like you can, reach behind your back and, put a 1 or a 2 or a 3 or, and what your fingers are doing. And that's not because you have to look at it, but because you know based on your proprioception and feedback from these muscles. So think of that in the neck. The neck is basically telling your brain what's going on. Now, if your neck is carrying tension, if it's had dysfunction, if there's some issues, like it will basically send a signal that's off, and that signal being off is likely to lead to dizziness, like a low-grade dizziness throughout the day. That's called cervicogenic dizziness, and that dizziness can also pop up as like a more intense room spinning type of feeling. And I would say what we find with vestibular migraine is mostly this as the problem. And largely because our healthcare system doesn't evaluate this like almost at all. Like it's very challenging to find a provider that would look at the neck and understand it well enough to say, yes, this is cervicogenic dizziness. This is dizziness from the neck. And so because it's overlooked so much, by the time someone comes to us with vestibular migraine, usually they've tried all the things, and then we're able to usually pretty easily. Like it's not like hidden in there. It's like, wow, like I barely touch any of your neck or shoulders, and you're like, it like lights you up. And so the other thing that makes this a little bit challenging to treat is usually it's been there, like the problem in the neck shoulders has been there for a long time, and it's all very sensitive, like it's ramped up. And so that's where, we have to calm the whole system down. And it's kind of this cyclical pattern of like, you're dizzy, so everything's tight, and you're kind of in this guarded state, which makes the problem of like the tension in your neck even greater, which makes it you dizzier. And so it's a hard cycle to get out of. But like I said, understanding the why usually comes down to, okay, your neck is the why. And so we need to start working through this and in order to get you relief. Okay. So that leads me into how to treat it. Okay. So the framework that we want to lay out is, what are the objective things? So if it's the inner ear and we've just like missed something in the inner ear, then we look at that. If it's the eyes and your visual system's all over the place, then we want to go down vision rehab and understand how to restore normal eye movements, what's called convergence, and things like this, okay? But ultimately, what we are experiencing is most of these people are having a neck issue that has been there for a long time. And so we need to restore function. We need to restore stability to both the neck and the shoulders so that these people are able to recalibrate, right? So the brain needs to understand what normal is, what normal movement in the neck is. And so it can basically start ignoring the neck again, and you can live your life without constantly being dizzy, okay? And so we want to evaluate the eyes, evaluate the inner ear, and then evaluate the neck, okay? When it comes to treating these areas, like hands-on techniques to restore mobility to the specific joints in the neck, to calm the shoulders down. Usually it's a progressive exercise program to try to add stability, improve function to the shoulders, to the neck. And then in the short term, there's simple techniques to kind of recalibrate the brain and how it perceives the dizziness. That could be things like grounding, or what's called habituation, meaning like slightly challenging these systems so that they become they're able to accommodate to just daily life. And so there's different things that we can do, both for the dizziness side, for the brain itself, but ultimately we need to take away any faulty signal that's coming from one of those three areas or multiple areas. And the neck is usually the most overlooked part of it, but because typically it's been there for so long and is in that kind of cyclical pattern of guardedness leading to dizziness, and guarded, and then I'm dizzy, and just keeps making the problem worse. We need to break that cycle and then give people tools in place to make sure that they're doing what they can to reduce the amount of tension through their neck on a daily basis. Okay, so that's vestibular migraine. That's how I would understand it. That's how we've understood it, and the framework we've put in place to help people with vestibular migraine here at Novera Headache Center. If you have vestibular migraine, it's the type of thing where I want you to reach out to us, whether it's a virtual or in-person discovery visit. Let's get the ball rolling. Understand your situation. Know that everyone's unique, okay? So we'd want to know the nuances of who you are, what you've been through, and hear your story. And then one of our headache specialists will want to, lay out a plan that makes sense in order for you to start making steps, laying the framework to calm these systems down so you can get out of this scenario. And we would love to help you do that. Like I said, we have offices in Colorado Springs and Parker, but we can also work with people in our virtual coaching plan. And then we would love for you to continue listening to the podcast. Please subscribe to this podcast, as it helps the algorithm, pushes it forward. And especially if you can write us a 5-star review, letting us know what you enjoy about the podcast. And we would love to hear from you. You can email us at hello@noveraheadachecenter.com or call the office 598 719-598-1010. And thank you all so much for listening to the Headache Doctor podcast week in, week out. As always, it's our mission to educate and empower everyone with headaches and migraines so you can break free from a life of fear of your next headache or migraine and dependence on medication. I'll see you next week.